Yuka, and I neglected to mention, Kimberly wanted me to mention that if you want to know anything more about our presenters, their bios are in your packet. Our third speaker is Charu Garg, Director of Population Health and Nutrition Research Program at the Institute for Human Development in New Delhi.
Good afternoon. And again, thank you very much for inviting me to speak in this forum and to present some of my work that I have been doing on financing coverage and utilization for informal sector workers in India. I have been actually working on, I am a health economist, so I've been working on financing coverage utilization, but my induction into workers' health came in just 2 years back with Ivan Ivanov actually bringing me into this area. So, and it has been very exciting last 2 years, working in India and in different countries related to this. Do I press this? No. So the outline of my presentation is like I'll talk a bit about the background, about the informal sector workers in India. What are the initiatives to cover the healthcare for workers? In this, I will mention both the formal and informal sector workers, because one of the things that I do want to say, though we have talked a lot about India, we've so far got a micro perspective from Mirai in a very nice way for the Seva organization, but she also has helped in putting this in perspective because governments, she's talked about the recommendations of universal health coverage and the recommendations that the government has accepted and is working on. So the third point that I will discuss here is success, challenges, and lessons learned, both in terms of population coverage, in terms of the depth of services covered, that is the benefits that the population gets, financial burden of healthcare on informal sector workers, which is one of the major things we are talking about, including the state and district level evidence. I do want to thank my two co-authors on the top of the slide where they have helped me with the district level evidence, which recently it's been collected for 2014 for 5 districts, and that data was analyzed. So I have something from there which I'll be able to share with you. Since it's a forum on public-private partnerships, I thought we should mention a bit on that. Finally, coverage and utilization, the point that was brought out by Peter yesterday, I thought it's a good thing to kind of clarify a bit on that, conclusion and way forward. In terms of the background, we've been hearing these figures, 94, 93, 94%. My institute has just brought out an India Labour Report 2014, and it's 83% of the informal sector workers. Like actually, this is not 2012, it is even later. So it's 83% of the workers are in informal, unorganized sector, and 9% of them are contractual, casual laborers, etc. in the formal sector. The primary industries which the government has recognized for these informal sector workers are agriculture, construction, shops and establishments, bidi and cigar manufacturing, waste management, eating places, transport, and home-based workers. The major occupational health problems that are faced by these workers are injuries due to accidents, chronic respiratory and lung diseases. The prominent ones are asthma, COPD, silicosis, musculoskeletal disorders, skin diseases, noise-induced hearing loss, poisoning, especially due to pesticides, lung cancer, leukemia, certain infectious, parasitic, and mental diseases. It is a very crowded slide, and I'm not going to kind of go over it completely, but all I want to say, these are the financing and delivery mechanisms to cover formal sector workers. And I'll just in my next slide do talk about what are the key points that emerge from here. But just to go over these major schemes are the Employee State Insurance Scheme, the central government health schemes, the Ministry of Defense and Ministry of Railways have their own health facilities to cover large number of workers in these who are working in these two ministries across the entire country. Then there are state government reimbursements and certain other private and public voluntary schemes. So what are the key points that emerge for these formal sector workers? Firstly, they are financed mainly by the government and the employers. There is a small premium that the employees have to pay. For example, in the central government health scheme, it varies from $1 to $8 depending upon your basic salary drawn. So it's really small that the people pay in terms of the premiums for this. The employee state insurance scheme is only for workers who are working in organizations employing more than 10 workers and earning less than 25,000 rupees. So, which is like less than $420. The financing for the scheme comes from the state government. 1/8 of the expenditure is borne by the state government, but the major part of it comes from the employers, 4.7% of wages, and employee 1.75% of the wages. And then some retired employees, etc., also pay a small amount, which is $2 annually. Then there are like the employees, the employees of the large corporate sector can also have their own schemes. Something like reimbursements. So if you go for outpatient care or go for inpatient care, you could be reimbursed up to a certain amount. You can have a lump sum payments that they're given certain amount for healthcare. Their employers have their own facilities in certain cases. And one of the major ones are like the railways and the defense, which I had mentioned some time back. And some of them also cover their employees under the private and the public voluntary insurance schemes. The comprehensive benefit package includes entire continuum of care, prevention, promotion, outpatient, inpatient, medicines, and diagnostics. Even in spite of that, people do go, and it is also available in all the public sector facilities, and there are some specific facilities for these employees and some of the impaneled private facilities. But it's interesting to note, like some of the very good hospitals are kind of moving out of, for example, I know the Fortis Hospital, which is a big one, is moving away from the central government health scheme because they don't get their payments on time. So it is going to be a challenge in that way. Then again, some of these people may not be covered under the private hospitals, which they do want to go to, which is one of the hospitals very popular for people in the upper income quintile using. So whether you use these facilities or you go for, definitely in terms of the financial protection, they are covered, but they do still incur some out-of-pocket expenditures. But the focus of our presentation is really the financing and delivery mechanisms for the informal sector workers. And here I'm going to talk about some of the major initiatives that have been put in place recently by the government. One is, of course, we've been talking all about it. Right from yesterday, we've been hearing about the Rashtriya Swasthya Bima Yojana, which covers about 400 districts across 27 states. Then there are state-specific schemes which are a variation of these variation of this national scheme, which is Rajiv Arogyashri. Andhra Pradesh, that's one of the states it covers. Karnataka, you have the Yashaswini scheme. Kerala, RSBY, comprehensive health insurance package. Then you have the Chief Minister's CHIS in Tamil Nadu. This slide also presents what is the coverage. 37 million in case of, actually that's a April 2014 figure in RSBY, 23 million in Andhra Pradesh, 3 million in Yashaswini, 1.6 million in Kerala, and 13.5 million in the Tamil Nadu scheme. Besides that, there are also other states like Himachal, Maharashtra, Meghalaya, who all have some variations of coverage. So one thing I want to bring out here is that it does not only cover people who are below the poverty line. Even the Rashtriya Swasthya Bima Yojana has started to include informal sector workers. So there is a positive step forward, and just away from BPL to include some of the people who are in the APL categories. And of course, as you would see, the Rajiv Arogyashri, for example, in Andhra Pradesh, which is number 2 on this, covers people with annual income below 75,000. So obviously, it is covering people who are above the poverty line. So what are the key points that emerge from these schemes? In terms of the financing, the center and the state split 75 and 25% of the financing. And the beneficiary just has to pay, it's like a registration fee. When you go with your smart card, you just pay that rupees 30, which is like 50 cents actually. Individual premiums in non-RSBY Yashaswini scheme, which we talked about, is slightly higher, which is rupees 200. But the other four schemes from Andhra Pradesh, Karnataka, Tamil Nadu, and Maharashtra, and also actually the Ministry of Textile covers weavers, and they are entirely 100% financed by the government. So therefore, we have contributory and non-contributory schemes we have been talking about in the morning. In the benefit package, it's mostly tertiary hospitalization and maternity, with limits on cash dispersed per unit per year per procedure. The annual inpatient benefits vary from $500 to $3,000 per family. And some schemes also cover secondary care. But there's no outpatient care. There is a small coverage for transportation, which is a limit of $20. And one of the scheme, Arogyashri, has also been putting up screening camps. Both government hospitals and private empaneled hospitals, where there were more than 7 million hospitalizations in 2014 in RSBY. Actually, I should have mentioned that. Both of them are providing services, but remember, it's only tertiary care. Mirai has talked a lot about the community-based health insurance scheme, but there was this Center for Health Market Innovations has put up a study with 32 schemes under the CBHI, and SEVA is, of course, the largest of them, which is run by communities, by hospitals, microfinance institutions, NGOs, etc. But again, the coverage is very low, and as Mirai was saying in the morning, how can we expand it and how can government help in scaling it up? Those are the kind of questions which still remain. And is it like, beneficial cost and all those other things will have to be looked at. I'm not going to, I did put up this cube because I just wanted to say that I am the fifth person showing it since yesterday. But why I put it up is because my entire presentation will be going on now who is covered, what interventions are provided, and what do people pay. So in terms of the population coverage, and I will talk about the coverage that I'm talking about, it's only enrollment. So if we look at coverage, Government of India had provided coverage to the entire population in public delivery system, even like 30 years back or before that. But were people using it? That is a big question. Okay, so it's not that we were not covered. All of us could go to a public facility and probably for just $1 could get an outpatient, or even less than that, could get an outpatient visit, but they're not enough. Are they available? Are there human resources? Are there infrastructure? That's a problem. They're not enough, so we couldn't do it. Are they accessible? Are people in rural areas able to go to them? Do they go to them? So then the question of acceptability comes. Is it acceptable? Is the quality acceptable? Are the waiting lines acceptable? So those are the kind of challenges we have to look at in coverage. So here we are only talking about coverage in terms of their enrollments. But it is, in terms of the RSBY, we do say there is, I would say it's a positive coverage in terms of people utilizing it also, as I showed you in terms of the number of hospitalizations. People are using it because it's not just public delivery system, it's also the private delivery system that is allowing for usage of these services, but it's only tertiary care again and again. So 55 million people, there is increased population coverage. In case we find that from 55 million people who were insured, now there are 370 million people in about 10 years, almost 1/4 of the population. It's a huge, I would say we have done very well on that. Okay, so there is definitely success in terms of increased population coverage. Formal workers, the coverage has increased, but not to a very large extent. Why? Because the formal workers themselves haven't increased. The point that was being raised yesterday, it's only then they keep contracting it out to the others. And one of the things I have to mention here, the employee state insurance scheme, which I just mentioned, covers worker less than 10. I was just looking at a statistics from the labor and employment surveys. 50% of the informal sector workers are actually working in employers' dwellings, employers' enterprises. So even if those 50% of informal sector workers could be covered, then we would have already covered that, a large percentage. And just by removing that ESIS limit, there is a bigger coverage that we would get. So that is one of the things that is immediate that we can think of. I have no idea, and probably I need to understand why, we have put that limit of 10 workers. That I do need some research on that. Okay. Then in terms of both formal and informal coverage of voluntary private insurance, it's gone up only from 24 to 70 million. The biggest increase has actually come from the 4 schemes, the national level RSBY, and the state-specific schemes in Tamil Nadu, Karnataka, and Andhra Pradesh. So they are actually covering 1/5 of India's population and mainly covering the poor and informal sector workers. So this is where the major coverage success is coming from. It is good. Another good point about it, there is a poverty link to this increased coverage, because it's again, it is, as I just mentioned, it's a BPL and just the informal sector workers, which are the APL. And almost the 2/3 of the increase is actually in population below the poverty line. So there is a success in terms of improved coverage. The challenge is that the services are limited. It's only tertiary care and some medicines and diagnostics if you get hospitalized. And that actually sometimes has led to that supplier-induced kind of services, because what happens is if you do get diagnostics and all, then probably both the doctor and the patient thinks that they should actually be covered under the, it might as well get hospitalized. So it's only tertiary care. RSPY, I think I've talked about this and I'm seeing a yellow light, so I'll just go away from this to the next slide, which is important. There is a limited financial protection. There is some financial protection, and my next 3 slides will talk of a very important thing. Have we been able to achieve some financial protection because of these initiatives that the government has put in place? This is the first slide where I'm showing at the macro level what is the picture. In terms of this is again the analysis of labor and employment survey. We find that 50% of the workers are self-employed, and about 30% of the workers are casual. Okay, there are 20% of the workers who are regular and have formal wages and salaries, but some of them are informal also. Okay, so what we are trying to say here is, if I look at the bottom, graph, what we have done is looked at what is the poor and vulnerable category, which is shown by dark blue, and the middle and higher income category showed by light blue. We find that the self-employed and the casual sector workers are actually in the poor and vulnerable category, which is less than 2 times the poverty line, was taken as a cutoff for defining the poor and vulnerable categories. Now, this is a famous chart from Peter Berman's paper, and what this chart shows, I know it's slightly small here, and I wonder if you guys can see it, but what it shows is really that what is the percentage of households falling below the poverty line due to healthcare expenditures. The largest percentage comes from second and third income quintile. Those are the people that fall below the poverty line if they incur out-of-pocket expenditures. And the most interesting part is, it is the dotted line, which is the outpatient expenditures. So it is not really hospitalization which is bringing so much the people below poverty line. Why? Because even earlier, if they were hospitalized, if the poor were getting hospitalized, they landed up in public facilities. So it was the outpatient expenditures and drugs. And even I have a paper on that which shows that it was mainly drug expenditures which was contributing to bringing people below the poverty line. So it is these two areas that need to be focused, and therefore financial protection comes in only when we move away from tertiary care to outpatient and medical and diagnostic care. So this is the important point that I do want to. At the state level also, there is a lot of evidence on showing like out-of-pocket expenditures have gone down. Andhra Pradesh recorded a slower growth in out-of-pocket payments for inpatient care, but the study still shows that in terms of the out-of-pocket payments, on an average it was US dollar 72, but if you were hospitalized, then a very recent study showed that for a hospitalization episode, it was rupees 1600 or 300 US dollars that had to be paid even if you were covered. So they were covered for 27,000 rupees, but they had to pay 16,000 rupees over and above the coverage that they got from RSBY. In Gujarat, 85% of hospitalized RSBY paid out of pocket. And a GIZ study recently showed for 3 states from Bihar, Uttarakhand, and Karnataka that actually there was a better financial protection. Enrolled people spent less than rupees 10,000 per hospitalization as compared to 17,000 by non-enrollees. Let me just skip Karnataka and go to the district level evidence that I found from one of the states that we did. This state has a good kind of institutional preparedness. It's higher in terms of sub-centers availability, doctors availability, bed availability, even the insurance coverage of the households are higher. But if you look at the formal and informal sector workers and financial burden on them, the first thing that is getting validated is what we were showing earlier. It is in the second and the third income quintile, most of the informal sector workers are there. It's the blue ones are the informal sector workers. So it is getting validated what we saw from the national level data that most people fall in second and third income quintile. The percentage of households that incur out-of-pocket expenditures are 40% for informal sector, 28% informal sector. Again, those facing catastrophic health expenditures, the households, the percentage is almost 14% in informal sector and 6.5% in formal sector. I want to make an important point here. My God, I had so much to say. The red light is blinking. So the important point I want to make here is that there is chronic illness for which also a lot of payments are made, and that's one point we were talking about yesterday that needs to be covered besides the outpatient care that I had mentioned earlier. This was just a point that I wanted to bring out because in terms of the there is increased coverage but limited utilization. We had done a study for NCDs. There were 5 NCDs covered. I just thought I'll just focus on one of them, which is the chronic respiratory diseases. And the problems are exactly what we've been talking about. People do not access service because they are not aware of it. Even if, and why the opportunity cost of it, then it's a stigma. If they know, they feel they might be TB, their employers may throw them out. So that kind of stigma is there. So that is the reason for demand side kind of problems in accessing the service. On the supply side, again, the same problems, lack of availability. The disease is masked. So we don't have enough doctors who can actually understand what is the disease about. They might just keep giving them kind of a cough and cold, whereas actually it is a much kind of a denser problem. So these are the kind of problems that are there. Public-private partnerships, there's a mixed bag. I think it's just the main point I want to bring in here in financing, central, state, everyone is playing a role. Corporate financing is there, but is limited to very few organized sector workers, and that's where we were talking about the supply chains, which should be covered. Schemes run by private third-party administrator, and they have an incentive because they are paid on per family enrolled. And provider also have an incentive, including the public provider. They also get paid for, so earlier the hospitals were getting budget from the governments, but now who is actually paying them? It is the money comes to them from their third-party insurer. So they have that incentive to improve the services, to improve the hospitals. I think I'll skip this slide, though it was quite interesting in terms of there is a commitment from the government, there is public-private partnerships, there is a better information, and there is the government has an objective to reduce high out-of-pocket payments. So it will sustain. At least I firmly believe it will sustain. Conclusions in this, I have already said, coverage has increased, but depth of coverage has not changed much. Coverage will improve utilization for informal sector workers when demand will improve by raising awareness and removing stigma through education about occupational diseases. And the risks on the supply side, risk assessments at workplace, early screening, and better trained doctors as first point of contact is required. So we need active measures in terms of population characteristics and disease pattern for specific geographic location to improve the depth of services for primary, secondary, prevention, screening, diagnosis, coverage for chronic diseases for informal workers, including medicines, diagnostics, and consultations, and cost of these activities need to be computed for government to include in their benefit package. We did it for Thailand, and we are still working on it. More research needs to be done to show the productivity. This is exactly for what we've been talking. I know, thank you. So corporate sector should play a role on the supply side kind of a thing. Finally, thank you so much. There is hope and health for India's poor at last. And one thing I do want to say, and I said it in another consultation, that if you have to protect the health of mother and child, you have to protect the health of the bread earner of the family. So please do think about the informal sector workers who are bringing money to the health of the family. Thank you so much.